And so we're going to move on now to still applying guidelines, but now in the surgical setting. And I'd like to introduce now Dr. Mitch Posner, who is the Chief and Section of General Surgery and Surgical Oncology at the University of Chicago. He's a Medical Director of the Clinical Cancer Programs, Physician-in-Chief of the Comprehensive Cancer Center, and a mentor to me for the 10 years that I've been at the University of Chicago. So thank you, Mitch.
Thank you, Dan, and thank you to Debbie's Dream Foundation for really the privilege of speaking this morning. Dan may think that I'm his mentor, but I can guarantee you he's the smarter of the two, and I learn from him every day. So I was asked to talk about surgery, and also was warned that the people in the room and on the webinar are, many instances, patients with not a lot of health care background, and that I should tailor my talk to those individuals, which I'm going to do. But I'm going to use a lot of the same slides that I use to talk to other physicians, actually, and I'll try to walk you through them. As Dan knows, you know, if a surgeon can understand it, anybody can understand it. So I'll try to work with you to show you what we're doing. This is incidence and mortality data for 2015 for stomach cancer. This shows the number of new cases expected in 2015 and the number of deaths. And while this looks maybe not so wonderful to many people, the fact is that for stomach cancer, we are doing better and better each year. So if I showed you the same slide for pancreatic cancer, those two bars would look exactly the same almost. The number of new cases a year almost equals the number of patients who unfortunately pass away each year. So we are making improvements. And you can see it here. These are looking at all patients with whatever stage of gastric cancer they have over successive decades. And you can see that their 5-year survivals have increased dramatically. And that's due to many, many factors. I will offer that to a great degree. It's due to a group of physicians, surgeons, radiation oncologists, medical oncologists working together, mainly to deliver better chemotherapy than we've ever had before. But there are many, many instances where there's been improvements, even in the way we approach things surgically, which I'll show you as well. But it's really a multidisciplinary approach that gives the best outcome. So I'll talk to you this morning about a number of factors related to surgery that everyone always asks when they come to see a surgeon, which is how many lymph nodes are you taking out? How much of my stomach are you going to take out? How are you going to put it back together? I usually tell them it's just simple plumbing. It's not that complicated. But what are also the side effects of going through gastric surgery? Because they're not minor and they can never be minimized. And then also talk to you about something that's been alluded here to before many times, is the value of laparoscopy as a staging tool. Probably the simplest surgery we can do, but probably has had the most impact actually in how we manage patients. And I'll also talk to you about the timing of therapy related to surgery. So this is the stomach, obviously. And on the left here are the lymph nodes that are in close proximity to the stomach that any surgeon with almost any talent can remove. And on the right are actually lymph nodes that go along the major blood vessels that come off of the aorta and supply the stomach and the organs around it. So on the right, these are called the level 2 or D2 lymph nodes, and these are called the D1 lymph nodes. And there's been a lot of controversy about what the extent of surgery should be to remove these lymph nodes. And this was a study that was done many, many years ago, actually, comparing the extended lymph node removal to the less extended lymph node removal. So a D2 is higher than a D1. And what you can see here on the right, it is very clear that in blue, that if you had a more extensive lymph node dissection, your chance of dying of gastric cancer is much less. And let's see if this works. And you can see here actually the true numbers, that almost 50% in the lesser group had died of gastric cancer, and reduced to around 35% if you actually had a more extensive resection. So at least theoretically, the potential value of better, more extensive surgery if it can be done safely. And this also looks at local recurrence or recurrence back in the area where the surgery is done. And essentially, you'll see the same thing. I'll highlight it here for if you have a lesser lymph node resection, the chance of the tumor coming back locally is around 40%. If you do a little better surgery, it's around 25%. So a marked reduction. For each individual person, that can make a huge difference. Now, we've talked about studies here. So on the right is that trial I just showed you comparing a more extensive resection to less. And you see the local recurrence is 25%. On the left here is the local recurrence rate in a trial that was one of the most seminal trials in gastric cancer in this country. It compared chemotherapy and radiation following surgery to surgery alone. And in those patients who received chemoradiotherapy and surgery, their local recurrence rate was 24%. On the trial on the right, the same number, there was no chemotherapy given in this trial. So what I'm trying to show you is that good, appropriate surgery actually makes a big difference to patients. So again, this is that trial on the left that used chemoradiotherapy versus surgery. And what you'll see is that the chance of surviving is about 40%. On the right, this is just surgery alone. You see the exact same survival with an extended, appropriate lymph node resection. So the question is, why is that the case? Well, as I'll show you in a second, or in a few minutes actually, that in the trial on the left, done in the United States, the chance of having an appropriate cancer operation in the United States was incredibly low. That in this trial, the majority of patients had a resection that involved removal of no lymph nodes whatsoever. So that's a problem. That's something we have to fix. So the guidelines, as Dr. Benson adequately lined out in exquisite form, is that in this country nowadays, that we recommend at least a D1 lymph node dissection, but more likely a D2 lymph node dissection if it can be done safely and by people who do this a lot. So surgical experience matters, and the volume of surgery within a hospital matters dramatically. And to give you the best analogy, I always give sports analogies. You know, if you're going to win the Super Bowl, you need an elite quarterback. There's no team in the NFL that can win without a great quarterback. That's why the Bears haven't won in 30 years. So it's very understandable. And it's a team approach, but you need people who are able to get the ball to the receiver. It's very simple. And that's how I think about how we do this as well. This was it's again a little bit complicated, but I'll talk to you about. This is now looking at what the value is of a minimally invasive approach to the removal of the stomach or portions of the stomach compared to an open approach. Surgical technology and surgical innovation has changed. We can now do operations for cancer through very minor incisions as compared to a big open resection that we used to do all the time. And I sat on this panel with many other people who were much smarter than I am. But we were trying to determine what the appropriateness of laparoscopic surgery was. And this was actually, we started this panel about 5 years ago. And appropriate meant that the benefit of the treatment far outweighed the risks so that it was at least worth considering, okay? And when you see here that we thought as a group that it was appropriate to potentially offer minimally invasive surgery for people with very early gastric cancer, those with limited disease, with no lymph node involvement, and that once we got beyond that, we actually all disagreed on what was the appropriate standard of care. The fact is, though, that minimally invasive surgery is here to stay, and it's here to stay for a good reason. So again, this is a complicated sort of graph and plot, but again, as a surgeon, the way I understand it is if you take the middle line here, and that bottom diamond crosses over the middle line, it means that both treatments offered are exactly equivalent. If it leans one way to the left or one way to the right, it means that one is better than the other. So this is looking at mortality from surgery, comparing a laparoscopic approach on the left to an open approach on the right. And you can see there's absolutely no difference. Now, if you look at length of stay, if you look at morbidity, meaning complications following surgery, unfortunately, these circles are off because this was transferred off of my original slides. Or if you look at survival, disease-free without the tumor coming back, or overall survival, they are either better with the minimally invasive approach or exactly the same. And what this should tell you is that as we move more towards finding surgery and offering it to people that has the potential to get them home faster, with less morbidity, less complications, back to work faster, this improves their quality of life, enhances their ability to get chemotherapy after surgery, that this is a good thing. But it still is critically important that the person you go to for that type of surgery is someone who's experienced in the management of patients with stomach cancer. Because if you go to somebody who's doing minimally invasive surgery because they do morbid obesity surgery, it's not the same thing. It's a different operation. And if you look at it stage for stage, again, minimally invasive approaches are exactly the same as open. They're equivalent, and they're a viable option. Doesn't mean it's right for everybody, but it's a viable option. So this was the trial that I showed you that compared chemotherapy and radiation to surgery alone, and again showed a benefit to chemoradiotherapy. But you'll notice that over 50% of patients actually had no lymph nodes removed. This is sinful in my mind that in this country that people are having gastric cancer surgery by people who do not understand the value of what an oncologic or a proper cancer operation should be. And it does make a difference. Even if it doesn't make a difference in survival, and we could argue that it does make a difference in terms of staging patients appropriately and getting them the right treatment. What changed the dynamic was this trial, which actually looked at, and this was mentioned by Dr. Mulcahy, is giving therapy before surgery in the form of chemotherapy without radiation and giving chemotherapy after surgery. And in that instance, as you can see here on the graph, those who got chemotherapy with surgery did much better than patients who had surgery alone, showing the value of giving chemotherapy in conjunction with an operation. It makes a huge difference. And if you look at actually looking at giving chemotherapy after surgery, again without radiation, this is a series of trials that are put together called a meta-analysis comparing it to surgery alone. Again, you see a marked benefit in terms of the addition of chemotherapy to surgery. Then finally the question comes up is, do we really need radiation? And again, this is a big issue because I just showed you earlier that surgery alone can give the same result as chemoradiotherapy if you're not having an adequate operation. But you want to have an adequate operation, then know if radiation makes a difference. This trial actually took patients and gave them either radiation plus chemo or chemo alone following adequate surgery, those who had a D2 operation, an adequate lymph node dissection. And it showed that there was no difference in disease-free survival, survival without the cancer coming back, in overall survival. But there were some patients, those with positive lymph nodes, who seemed to benefit from radiation therapy. But again, this comes into the issue of speaking to your physicians about what the actual value is. Because if you look at it, the difference in 3-year survival, disease-free survival, was only 3% with the addition of radiation. Which means, actually let me go back, that you actually have to treat 20 patients to prevent tumor from coming back in one patient. Only one patient will benefit out of 20. Now obviously if you're that one patient, that makes a huge difference to you. But if you're the 19 patients who are getting treatment that doesn't help you, that also makes a difference to them. So these are the issues that have to be discussed with your physicians. So I'm going to show you things with relationship to surgery. Hopefully I won't get anybody ill in the room. But in terms of stomach cancer, and I'm not going to focus on esophageal cancer, although it's one of my major interests, but it gets too complicated. I would just focus on stomach cancer. There's really 2 operations that we can do. One is removal of the entire stomach, or the removal of a portion of the stomach. So the entire stomach here on the left and a portion of the stomach here on the right. Okay. And then the question is, how do we reconstruct people after that? And if you do a partial stomach removal, there's really 3 ways to put the patient back together so that the plumbing works. On the left, you attach the duodenum, which is the first part of the intestine of the stomach, back to the stomach itself. We rarely do that in gastric cancer, actually. In fact, I don't know anybody who really does that. The other is what's called a Billroth 2. This is named after a surgeon from Vienna who was alive 200 years ago, but the name still sticks. And this means that we go a little farther down and hook up the stomach to the small intestine. And I'll show you why one may be better than the other down the road. The third option, which is a little bit more complicated, is that we divide, again, we remove a portion of the stomach here, and instead of hooking either the duodenum or the jejunum right up, we actually divide the jejunum here, or the first part of the small intestine, bring the downstream end up to the stomach, and the other end that we cut down here in the form of a Y. And there is value to this because in many instances it provides a sort of a normal route for the bile to mix in with the nutrients that come into your mouth and into your stomach, and makes for a better digestive result. And there's 2 ways actually to do this connection. One is a straight tube, and the other is to create a pouch, with the idea if we make a pouch that there's more capacity to allow people to eat more normally. And I'll show you whether that really has value or not downstream. So in my own practice, I do this Y reconstruction for every patient, whether they have part of their stomach removed or they have all of their stomach removed. And we could argue about why I do that, but I do think that the results are better for patients and that they handle it better. There are complications from any operation we do. There's risks, there's obviously benefits, but you can never, I think, minimize the complications. Early complications, devastating ones, are what we call leaks that can come from the duodenum or where you hook up the stomach. And there are ways to diagnose that very easily, or people can get an obstruction following surgery. Many times that obstruction can be to an internal hernia, not a hernia that comes through your skin, but there are many avenues for intestines to sneak around in bad places when we move things in a different way from the way God created you. So those are things we always have to be aware of. There are also late complications that everyone who has surgery should understand. You can get a narrowing where we hook the intestine back up to the stomach. That's called an anastomotic stricture. And as you can see here, the opening looks quite small because it's been scarred down, and therefore patients won't be able to eat appropriately. You can also get ulcerations where we hook the stomach up to the jejunum. It actually creates an environment that's conducive to getting an ulcer. That usually can be treated just with medication. You all have heard of a dumping syndrome. That's when people who have had either a portion of their stomach removed or all their stomach removed, that the food passes into their intestines quite quickly in certain patients. And it can cause symptoms like sweating, abdominal pain, immediate diarrhea. It can make your life quite miserable. There are ways, though, that we can control that just with diet, actually, in the vast majority of patients, and also understanding that it only occurs really in about 10 to 15% of patients. You can also get reflux. You really won't get reflux of acid anymore because we've eliminated the ability to create acid. But bile can cause the same problems and cause the same symptoms. Again, can be treated usually with medication. And then there are other syndromes that I won't focus on. I did mention to you about whether a pouch makes a difference when we remove the whole stomach. And without going through this in great detail, there is data that shows that a pouch may actually make it easier for patients to maintain their nutrition and their nutritional state and be able to eat in a more, quote, normal fashion. And I won't go through this data, it's too complicated. What has become sort of a standard of care for those who treat patients with gastric cancer all the time is the idea of a laparoscopy. Now, laparoscopy can be used in 2 ways. One is that if you go to surgery directly with no chemotherapy beforehand, we use it to determine if the cancer is spread, and if it does, then surgery is not appropriate, and therefore we stop and don't put people through a big operation that's not going to help them. The other and more common method of using a laparoscopy now is to stage patients to determine what pathway they should go on in terms of their treatment. So when I see a patient with anything but a very early stage gastric cancer and confer with Dr. Catenacci all the time, we frequently take them to laparoscopy, again, a relatively minor surgical procedure, understanding that no surgery is minor. But we put a scope in, we look around. If there's no spread of the disease, we're happy. But if there isn't spread of disease, we also put fluid in the belly. And it'll sound weird, but we shake up the belly, agitate it a little bit, and then collect that fluid, send that sample to our pathologist or cytologist. They can actually detect single cancer cells in that fluid. And I'll show you why that's important, because if we detect those cells, then probably, again, surgery is not appropriate, except if we're looking to change things on a clinical trial. So you can see simply, by looking through a laparoscope, you can see pretty much everything. This is the liver, this is the diaphragm up here, and this is just the fat around the stomach. And you can find actually implants of tumor, and if you find that surgery is not the right thing to do, chemotherapy is clearly the next avenue. There was a study, though, done on patients who actually had a laparoscopy with these washings, as we call it, that were positive, and then followed patients who had positive washings to determine how they do and whether chemotherapy, once you find these washings, makes a difference. So I'll quickly walk you through it because I think it's impossible. Around 1,200 patients treated with gastric cancer at a laparoscopy. About 23% of them had cytology that was positive. And that means these patients, these are the patients with positive cytology, these are patients who are found to have gross metastatic disease. If we then focus on those patients, you see that those patients who have just washings that are positive, just single cells, they do better than patients who have gross metastatic disease on a laparoscopy, which is what you expect. They have a lower tumor burden. And then if you look at those patients who just have those findings and then treat them with chemotherapy, there's a certain percentage of those patients which will then convert. If you repeat the laparoscopy, they won't have any cancer cells in their belly anymore. And those patients who do not, who've actually responded to chemotherapy, do much better than patients who don't, much, much better. But, and I think the important message to deliver is that if they then go on to surgery, surgery does actually not help those patients as far as we can tell at this moment. Now, it may be when we develop better chemotherapy that it will help them, but that should only be done on a trial at this point. So it's important to know that the chemotherapy is making a huge difference, but removing their whole stomach may add no value to that therapy if they only have single cells within their belly once we put these washings in and collect them. Finally, I just wanted to touch on one subject just very quickly because I think it is important. Dr. Jung mentioned hereditary diffuse gastric cancer. That's when patients have an identifiable mutation in a specific gene that when it's mutated doesn't have that, the cells don't have the stickiness that prevent them from spreading, and therefore there's a propensity for them to spread. We don't have to go into the genetics of it. We can identify patients by their family history who actually are at risk for this type of gastric cancer. And it's important to note that the treatment for these patients, the only treatment we have right now, is to remove their whole stomach before they get a bad cancer. And if we do that, we can cure those patients. And the reason that's important is that when you then take these patients who have this gene mutation and do an endoscopy, because you might say, why don't we just follow them carefully with an endoscopy, and when we find the cancer, then operate on them. It makes perfect sense to me. I'm sure it makes perfect sense to you. But unfortunately, as you see here, you can't find those cells on endoscopy. So only about 10%, if you biopsy those patients with this gene mutation, will you find cancer before surgery. But then if you operate on those patients, 100% of them will have cancer in their stomach that you can't identify by endoscopy. This is a study which was done by our group, which shows the exact same theme. Only about 30% were identified by biopsies with endoscopy, but 88% of those patients we could not identify. So screening them and then taking out their whole stomach, while agreeably is extreme, prevents them from getting a very, very aggressive cancer that we would not be able to treat adequately. So I'm very happy to answer any questions. And again, I want to thank Debbie's Dream Foundation for really the honor of asking me to speak with you today. I think this is very important, and I'm happy to answer any questions you may have.
Thank you, Dr. Posner. We always need a good plumber, and it's always at a center of excellence that does a lot of these surgeries, as you mentioned. So we have one question here, and if there are any questions, of course, ask the people with the microphones. We have one on the webcam. The question is, can you please discuss the effectiveness and side effects of HIPEC, and tell us what that is, used during a total gastrectomy or abdominal surgery for stomach cancer?
So
In a nutshell.
Very complicated. HIPEC is a procedure that involves when patients have spread of cancer within the belly cavity, or what we call the peritoneal cavity, and is limited to the peritoneal cavity. There is a group of individuals who strongly believe that if we clean out all of that cancer and then wash the belly with chemotherapy, not intravenously, but within the belly cavity, that has the potential to improve their outcome. In gastric cancer, I think it is still very controversial. There was one study actually that was done in Europe that actually showed a benefit to it. I think many of us are unsure if that has true value yet, because it has not been tested in adequate trials comparing those patients to standard current effective chemotherapy. So we don't know the answer. I think that it is certainly a reasonable question to ask and to try to get answered. But my own feeling is, and I can only obviously talk about my own opinion, I'm uncertain of whether it has value or not at this point. But I do think it needs to be tested and the question answered.
Any other panelists that have a comment on HIPEC from a medical oncology standpoint? Dr. Benson?
It's highly controversial. I think the best indication is there are individuals who have very low-grade neoplasms, typically from an appendix cancer, where it's considered, but it's been very hard to do clinical trials. There was an attempt, for example, across the U.S. for a colon trial with HIPEC, which unfortunately was not completed. So most of the data are not at the level of randomized clinical trials. And it's part of what I mentioned before. We don't have a lot of Category 1 evidence in terms of many of these things that we consider.
There's definitely a consensus that there's no consensus. And that's always the time to do clinical trials. So another question that came up earlier was if a patient has a stent and the ability to give radiation or chemo, having a stent, particularly for an esophagus cancer, does that affect the ability, better or worse, the same, to do an adequate surgery if one is placed?
No, stents can be very effective, especially in somebody who has a tumor at the junction of the stomach and the esophagus, what we call a GE junction cancer. And for patients who need to maintain their nutrition during preoperative, before surgery, chemotherapy and radiation, it's a great way to provide them with a normal way of getting food in. And it really doesn't affect, in terms of myself, the surgical procedure whatsoever. Those stents are pretty straightforward to remove, and it doesn't compromise the surgery at all. The one thing to be aware of, though, with stents, especially those that are placed in the esophagus, the tumor literally anchors that stent, so it keeps it where it's placed. Once patients start responding to treatment and the tumor shrinks away, the stent can begin to move. And it can actually move into the stomach and actually get passed out when a patient has a bowel movement, or it can get stuck in the intestine and cause a blockage. So everyone has to be aware of these issues because they come up. But in general, a stent is not a bad thing, and it actually avoids what is the worst thing for us, which is someone deciding that a patient needs to be fed through a feeding tube in their stomach, and they can put a feeding tube in and actually compromise the surgery that we would want to do down the road, which is a huge problem. So stents are good.
Okay. Another thing, just to maybe give some tips about what you might tell patients and families, how to best prepare before a surgery and what to expect right after surgery, how often you see them after, and that kind of thing?
Yeah, so, I think that, my job is to educate patients to understand the disease as well as I do. Now, you may say you're a surgeon, so that's not too hard to make them understand that. But I really feel that patients are much better off once they clearly understand all of the implications of what we do. And at the same time, I consider myself an oncologist that just happens to be a surgeon. And therefore, and Dan knows this, when I operate on my patients, I see them forever. It doesn't change. I see them every few months for the first 2 years, which is the most likely time they will recur if they're going to. And then every 6 months till they get to 5 years, and then every year after that. And again, I'm biased to this, but the relationship between a surgeon and their patient is in some ways, somewhat different because of the things we do to people, and there becomes an attachment that's very strong, actually. So even when I try to tell people they don't need to see me anymore, they still come back.